So I used to be a United Healthcare guy, Aetna, 25 years in managed care, contract negotiating, business development, provider side, an opportunity for 5 years to be a compliance officer for a health plan, hence all my lawyer questions. And was in Nashville, Tennessee. I'm from California, did all my time in California managed care. Moved to Youngstown, Ohio, because my wife took a position with Duane Seckwer's Mercy Health System and was working remotely at the time, and unfortunately got laid off. Due to acquisition, and the health plan market is consolidating. And so I don't want to move from Youngstown. I do, just after my son graduates high school. Let me rephrase that. I'm getting the hell out of there. But then telemedicine is something I've wanted to do when I was on the plan side. I was for years. Back when Milton was starting his company, as a matter of fact. And I couldn't figure it out. Here I was the chief network officer for one of the premier Medicaid plans in Southern California, and I couldn't really put the dots together to make it work, and I was willing to pay for it. And so I've got a group of advisors put together. We're an infant, and we've only been around for a few months now, and connected with Milton and said I wanted to do telehealth. And he said, well, what part of it? And I said, well, all of it. And he said, you can't do all of it. And I said, well, you do, and why can't I, right? And he said, give me a call back when you've got something a little more tangible to talk about, which he was, it was much more gracious than that. But mental health is where we're at right now, and I want to talk about and how it ties in with physical health and the disconnection. And integrating specifically behavioral health with physical health is a big piece of it. And this is where I think telemedicine can make a difference and is part of the bridge, if you will, in really changing the dynamic of healthcare delivery. And so just through integration of 45 million million people in America with severe mental illness. Substance abuse is 10 to 15 million with substance abuse is, I believe it's way more than that. But if it's 1 in 5, there's some people suffering from substance abuse in this room. Okay, if you're not, you have family that does. And so I'm going to talk a little bit about here. The idea for our long-term goal is to build integrated behavioral health models across the U.S. A couple of interesting facts about mental health is that of the last year, family admitted to actually taking advantage of and seeking mental health services. You can see a big chunk of them never even sought help. Or if they do, they sought help through cash. Hence the weight and the scale not being connected. Because United Healthcare does have all that information. Being myself, I paid cash too to go see a mental health provider. There's still a stigma attached to it. Overdose deaths. Now this is a graph that shows the amount of overdose deaths. It's almost 200 a day are dying of overdose in America. That's crazy. It's more than guns. And death is the amount of destruction in the families that's taking place. My mom, for a personal example, died 11 years ago. Feels like yesterday. And I'm almost 50, So if you think about it as a parent who loses a 22-year-old, which is the example of the CEO of a company called Shatterproof.org, which is a really amazing organization that is driving change in the mental health arena with legislation and evidence-based care models for substance abuse providers. Hopefully, this will be a catalyst for some really good change in improving quality of life in general. Now, from a mental health spending versus GDP for the country, again, some slides about how successful America is knocking out of the park. This is how much we spend on mental health compared to other companies. Case upper right, big orange arrow is us, leading the game. And then that's us on how much we spend per capita on psychiatric hospitals. Republican, Democrat, doesn't matter. I think we all would agree Ronald Reagan was one of his legacies. I think everyone agrees. So we're spending so much money yet, you know, there's no spending for allocate. It's costing us a huge amount. We have no allocation for a simple hospital, for example. And so telehealth is where I think is going to play into where we haven't heard talk about, I've got 5 minutes, is alternative payment models. And this will get the attention of the health plans that are looking to move into value-based payment methodologies and whatnot. And I think telehealth has got a great opportunity to be part of that solution. And for those of you who are not familiar with this, on the lower left is our old friend fee-for-service, and it's a sliding scale going up to a grouping of physicians or providers working together, and what better mechanism to facilitate that than telehealth. It doesn't replace face-to-face, it enhances it. And also, the reimbursement for the providers goes up. So that's what VBP and shared risk models are for my health plan friends, anybody who's familiar with that market. This is what I've done for 25 years, and I see as being a big piece of it. These are some examples of an integrated delivery model. I used one on the right, for example, is substance abuse. You know, there's a lot involved in substance abuse. It's 12 to 18 months of treatment. For some, they lose everything, home, family, job. They need transitional housing. They need, you know, the primary care is in there, social worker. In 32 states, there's something called a peer recovery coach is a Medicaid license piece of it. And then this is basically the same circle, and everything in orange, there's an opportunity for telehealth to be utilized. And again, the slides are here, but getting away from the physician as the piece of it, the APRN, you know, every state is a little bit different, social worker. There's a lot of opportunities to utilize, if you're flexible, with making a difference in people's lives. And then this is where we're at now from trying to get to an integrated model, which I thought this was great when I found this. And you have no idea how long it took me to find where that quote, where I got the slide from. And this is the ultimate goal of an integrated behavioral health model. And again, when you look at the slides, you'll see that telehealth, if you really think about it, or fits into all this. This is based out of New Zealand, which is a case study that took place. It's a case study on New Zealand, which had a major earthquake several years ago, which impacted hospital bed capacity. And they developed integrated delivery care model because they didn't have enough beds for the population. And there's a report out there, I've linked it down there at the website, where the results of that have shown true, where the need for bed capacity is actually not increased like they suspected. Bed capacity means cost, which means better outcomes, the 3-tiered target, the right place, right level of care, and right place of service. That's kind of where I see telehealth fitting in. It's everywhere and it's nowhere, if you will. It never replaces the face-to-face relationship that the plans need to see and the patients. I too, but my watch went off last night when my son's blood sugar hit 250, and he's in Ohio. So I paid cash for that product. I was lucky enough. I called my wife and said, hey, you guys need to wake up, check my son's blood sugar. He's level type 1 diabetic. So the laws need to get fixed. And people, luckily like us in this room, we have the capabilities to pay for such things. But those populations that don't, 13 million people in California alone are on Medicaid. And the plans will participate if appropriately motivated in such a model. You can't just make a pitch to save money. You have to have a business model that creates leverage and a foothold in a market that they're looking to go for. Luckily, in Medicaid, over the next 3 years, I've got a calendar up of the Medicaid RFPs for each state, and each state going, California is one of them, and most of the plans that are here are making bids on them. And so I'll be already in those states working on models like this, ready to meet them when they get here to do their RFP. And that's how you'll get this model in place in Medicaid, and then it'll percolate into Medicare Advantage and commercial products. Any questions? I go too fast? Buzzkill?
Any questions?
I've got a quick question. With your, I'll say treatment plans for the opioid overdose epidemic, what is your explanation of what fentanyl plays in that problem?
Well, I'm not a clinician, right? So fentanyl, though, is a bigger, what's happening with opioids is fentanyl is the next step up. It's the bigger hit.
Yeah, well, fentanyl is really more of a problem than traditional prescribed opioids.
And then they move into heroin is the problem because it's cheaper on the black market.
But as far as on the street deaths, et cetera, they're really not through prescriptive medicines, are they?
According to the slide I pulled there was opioid, yes,
No.
is where I pulled that. So,
Okay, thanks.
yeah.
Great. Thank you so much.